Hello, and thank you for joining us tonight for the Contraceptive Challenges webinar in partnership with St George Hospital. My name is Bertha and I'm the CPD and Events Manager at Central Eastern Sydney CESPHN. Before we begin, I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work. I recognise the continuing connection to land, water and community and pay respect to elders past, present and emerging. I also extend that respect to any Aboriginal colleagues joining us tonight. We would love to get GPs involved in with case discussions. So on the screen is the remaining topics for 2024. If you have any cases that you would like to be included, please email the de-identified cases to Kylie. Her email's on the screen, and these will be sent to the appropriate speakers for consideration with their presentations. Primary Health Award nominations are now open. These nominations close on June 30 and winners will receive a 2,000 grant towards furthering their work. And lastly, CESPHN has launched the CESPHN Health and Community Service Directory, which is designed to help people in our region better understand the programs, services and groups that are available in our community. You can visit the directory via servicedirectory.cesphn.org.au. And I would like to introduce our GP facilitator tonight, Dr. Martina Gleeson, and our first presenter tonight, who is Noreen Murray.
Good evening, everybody. Welcome to tonight's presentation. So my name is Noreen Murray. I'm the Midwifery Unit Manager of Women's and Children's Outpatients at St George Public Hospital. So tonight I'm just going to give you a very quick update in all things GP shared care. We've made some changes we had an adverse outcome late last year, and in looking into the trajectory of what happened for that woman, it gave us an opportunity to look into our systems and how we operate GP shared care, although there was no kind of blame to either the hospital or the GP, but it was just a lack of engagement of the woman really. And as I said, it gave us opportunity for improvement. In the background of this, we had a long-standing midwife called Julie Curtis, who managed GP shared care for many years and did an exceptional job. And then after COVID, there was a total change of staffing, and that sort of played out. However, so the things that we've looked at is we have reviewed the system and the criteria. So we make sure that the eligibility of the women attending GP shared care is category A or category B in the midwifery consultation guidelines, with respect to, if we choose a category B, that the obstetric consultant has input to determine whether the woman is suitable or not for GP shared care. We've developed a database which has got lots of detail in terms of the woman, her parity, whether the GP is accredited or not. We make sure that he is, he or she. If the GP isn't, we offer a different GP, and if the woman still doesn't want to partake, she comes back to the hospital. Or in the case of a woman, which we've had the case of, wanting to continue with the uncredited GP, then we make sure she signs a form to say, look, this is not what we recommend, and so forth. We also have detail in the database whether the woman's had her morphology scan, her bloods, whether she's attending her appointments and so forth. This will give us a quick snapshot then month by month of each woman and where we're up to, so that nobody gets lost to follow up or we're not missing anything like various blood tests and so forth. We've got a new business rule, clinical business rule for GP shared care, which is hot off the press today and will be circulated. And again, it describes the role of the GP liaison midwife. It describes the eligibility criteria and the process of referral and what happens to the woman once she gets into the hospital. We've also developed a new email address for the GPs to reach the GP shared care liaison midwife. It's on the screen. It's also been sent to the PHN to update in the newsletter so GPs can be aware of it. So the GP liaison midwife, she does the role 2 days a week. So one day is a clinical day and one day then is an administration day. On that day, she will answer all emails. So these emails are not urgent, they're just a means of communication. If there's anything urgent regarding the service, the GP can contact me directly by calling the hospital and asking for me on my pager 582. If it's a clinical emergency, they ring the hospital and ask to speak to the obstetric registrar on page 898, and that's all on the PHN Pro protocol. We'll endeavour to answer the emails, it will be answered within 7 days or sooner. Historically, one of the considerations or problems that GPs talk about is the communication between the hospital and the GPs. So again, with regard to tightening up our processes, we've reviewed the letters we sent to the GP. So again, the GP liaison will ensure that anyone who comes onto the programme, the acceptance letter goes to the GP. And if it's a negation, if the woman is not suitable for GP shared care, a letter regarding that will also be sent to her, to the GP. We're also making sure that any pathology ordered by the hospital that has the GP's details on the request form as well. So the results also go to the GP, so for inclusion. Another thing just up to note lately, we've just noticed an increase in influenza and COVID. We've got many women over the last couple of weeks calling in with, quite sick, particularly with influenza A. So we're obviously encouraging women to get the flu vaccination. The clinical staff at the hospital are back wearing masks again for clinical care to protect the staff, because again, we've got huge sick leave at the hospital at the moment, which is an issue. I thought I'd just include this flow chart as well from the Preterm Birth Collaborative. There's just a few more criteria added in for women who can have progesterone. So again, if women with low risk for preterm birth, if we notice that they have a shortened cervix at 20 weeks, we can offer progesterone. Women who have other risk factors like LETS procedures, previous cesarean section or full dilatation, if they have a shortened cervix at 20 weeks, they will be recommended anyway for surveillance scans at 16, 20 and 24 weeks. But if the cervix is shortened, they obviously commenced on progesterone 200. And for the high risk women that have had pregnancy loss greater than 15 and less than 34 weeks, they are recommended progesterone early in pregnancy, and cerclage if necessary. And that is it from me.
Thanks so much for the update, Noreen. If you'd like to share your slides with me, we can send them out to the attendees tonight.
No trouble at all.
Great, thanks so much.
No trouble. I'll just
okay, and now I would like to introduce Associate Professor Greg Davis, who's a Senior Staff Specialist, Department of Women's Health at St George Hospital.
I'm going to talk about basic physiology, but not much of that. What's available, I'm making a choice. I'm going to talk about oral contraceptive pills, the pluses and minuses, some pharmacology, which one you should choose, the long-acting reversible contraceptives, and then I'm going to finish with some cases to discuss that sort of talk about these issues. My clinical approach to contraception. So I'm not going to give you a lecture about contraception. We do have to cover some bits, but this is very much, I'm aiming it to be very practical, and this is what I do in my clinical practice. So next slide, please, Bertha. You will have seen this picture many times, but we need to just briefly summarize it. So on the top, you have what's happening in the pituitary. So FSH stimulates the development of the follicles, which you can see on the next line down. And as the follicles develop, they produce estrogen. And as the estrogen rises, that actually inhibits the FSH, but then stimulates the LH surge, which then brings on ovulation. And after ovulation, you'll see in the third line down, you get the production of progesterone, which rises, and then if the woman doesn't get pregnant, it falls. And this is a really important concept to be aware of. It's actually the fall in the progesterone which leads to the woman actually bleeding. And you'll see down the bottom, this is what's happening in the endometrium. In the first half of the cycle, it's proliferating. The second half of the cycle, it develops all these curly glands and becomes secretory, and then breaks down with the period. Next slide, please. So how do they work? Progestins prevent, so progestins is the overall term for progesterone is the only natural occurring one. but the whole family are called progestins. So they inhibit the LH surge, which suppresses ovulation, but they also thicken the cervical mucus so the tadpoles can't get through and reduce fallopian tube motility. Estrogens prevent pregnancy by inhibiting FSH so that you then don't get follicles developing. But you really don't, the reason they put estrogens in the combined pill was really to try and reduce the amount of breakthrough bleeding, because that is the problem with progestins. Next, please. So what are the options? So there's obviously the barrier methods, male, female condoms, the diaphragm, cycle planning, or otherwise called Russian roulette is how I described it, withdrawal, and I'm not going to talk about these things tonight. So you have combined pills, the NuvaRing, the long-acting reversible contraceptive or LARCs. So that's Depo, Provera, Implanon, the hormonal and copper IUDs, and sterilization, which I'm not going to talk about tonight either. Next, please. Now, this is a fantastic page that you can download from Family Planning, and you'll see, and it's really good for discussing it with your patients, so you can sit down and discuss it with them. So you'll see along the top, these methods are greater than 99% effective. So Implanon, the Mirena, the copper IUD, sterilization. And the next row down, you'll actually see that underneath each of those, it's got used perfectly and used typically. And with all the next row down, used perfectly, the contraceptive rate is fantastic, but used in typical fashion, it's much less good. So you have Depo-Provera, which is 99.8% effective if used properly, but if the woman doesn't remember to go and get it repeated, then it doesn't work, obviously, as well. The vaginal ring, the NuvaRing, the pill, and the progesterone-only pill, and then down the bottom, it's got the less effective methods. So condoms, internal condoms, so female condoms, diaphragm, and these two, I don't ever prescribe those, and that's because I don't have many women coming along asking for them. And I think unless you're doing a lot of them, then probably best to leave these to family planning. And down the other side, it gives you what is the woman's risk of getting pregnant. So the top line, 1 in 100, 1 to 7 in 100, 1 to 24 in 100. So next slide, please. So which do you use? I believe there are a few times in medicine when the treatment options are so great, there is no right choice. And what I'm going to tell you tonight is what I do. So it's a balance between the goals of treatment and what the woman wants. Next, please. So what are the goals? Obviously, contraception is one, but another really important one, certainly in my practice, is bleeding control. So, and it may well be both. Then you're controlling pain, premenstrual symptoms, acne as well. The other factors to take into account is compliance an issue. And if it's going to be an issue, like it is with many women with young children, that really rules out taking the OCP or a progesterone-only pill. Then, of course, medical conditions like hypertension, obesity, smoking, a history of thromboembolism, those are other important factors. Next, please. So pills, what are the pluses and minuses? The pluses, they stop ovulation, they reduce menstrual flow and therefore pain. And I think it's really helpful to explain to women that, you know, when the days that they have heavy flow are the days that they have the most pain, usually. And so you explain to them that if we reduce their menstrual flow, then usually their pain will improve as well. It's good for their skin. It reduces the long-term risk of endometriosis, endometrial and ovarian cancer. They can skip their periods completely, and fertility returns immediately. They stop taking the pill. The minuses are that they've got to take it every day. They will often get nausea and breast tenderness initially. They may get breakthrough bleeding. And a big one really is mood changes. And it's something that I never used to take into consideration enough, I think. And there are a lot of women who stop the pill because they just feel off when they're on the pill. And I think it's something you really need to take into consideration. Next, please, Beth. The risks I mentioned briefly, risk of thromboembolism, there's a 3 to 4-fold increase in risk. So if they have other risk factors, then the combined pill is not for them. There's a slight increase in arterial disease. So there are other risk factors with that particular smoking over the age of 35, vascular complications if they get migraine with aura. But really important also to realize that in big epidemiological studies, users of the OCP actually have lower death rates from any cause for each age than non-users. And estradiol, which is one of the newer estrogens, and I'll explain that to you shortly, has less impact on the lipids and coagulation factors, and therefore theoretically a lower cardiovascular risk. Next. So what are the pills? And there are a million of them. So I was mentioned estradiol before. Ethinyl estradiol estradiol is what circulates in the body. Ethinyl estradiol is a synthetic estrogen and combined with levonorgestrel or norethistérone. And both levonorgestrel and norethistérone are synthetic, but they're derived from testosterone. And so that is why they will have some androgenic side effects. So microgynon, Levlin, triphasic preparations, they've been around forever. They're all PBS listed and they tend to be cheaper. Although one of the sort of third generation pills, Marvelon, is still reasonably cheap, but it has a different progesterone in it. And many people now prescribe Diane 35, which is touted as being anti-androgenic, but really is no more anti-androgenic than any of the other newer pills. Next, please. Then you have all the newer ones, which is confusing. So these are not PBS listed, so they're all more expensive. So Yaz and Yasmin have ethinyl estradiol and drospirenone, which is an aldosterone derivative. And I'll talk about that shortly. Valat has a different ethinyl estradiol and a different progesterone again. Then Clara is a quadriphasic one that again has estradiol, so therefore theoretically, anyway, less cardiovascular risk. And Denagest, Zoili has estradiol and another progesterone, Megestrol. Then you can get the progesterone-only pill. Now, this is not like the old Microlot and mini pill. This is drospirenone. So drospirenone is an aldosterone derivative, and so it's good for women also who might suffer from fluid retention on the pill, and or even if that's hard to know, if they complain of that, then this is a good response to that, to say that they put this on because it is an aldosterone derivative. And Nextstellis is a newer one, and estetrol is supposedly a natural estrogen because it's found in the fetus, and so theoretically again will have less effect on hemostasis. Next, please. Now, just to confuse you completely, this is a list of the pills in Australia in 2015, and I've printed this sheet off and keep it in my drawer at work to refer to it. And I'm not suggesting that we should be going through that at all, but it is a good reference. There are a few more on that, like the Nextstellis is not on this particular sheet, but pretty much everything else is on that sheet. Next, please. What about side effects? So we mentioned thrombosis. This is an interesting statistic, I think. And the absolute increase in risk from the OCPs is less than 1 in 1,000, which is much, much less than the risk in unwanted pregnancy. I mentioned mood changes, which I think are really important. And I also mentioned nausea, breast tenderness, and irregular bleeding. Next, please. This is from the same Australian prescriber paper. So the risk of venous thromboembolism, you'll see, and it's the rate per 10,000 woman years. So that's the same as 10,000 women studied for 1 year. So the background rate is 2. If they use the pill, it's about 3 to 4 times. When they're pregnant, it's about 15 times. And immediately postpartum, it's 150 to 200 times. So it puts the pill in perspective, I feel. Next. So what do I choose? So I usually start with Yaz because it's a low dose. It's got the drospirenone in it, and it's marketed as causes less weight gain. It's good for the skin, but it's expensive. It's $80-something a packet. The alternatives, Femtab is the only 20 microgram pill that's PBS listed, so it's cheaper. As I said, Marvelon's pretty cheap, and it tends to be the other one that I will change to because it's got the different progesterone in it. I warn them of the risks, and I usually will start it cyclically because that's what women are used to. And next. The reasons to change. If you're going to change, so if it is a mood problem, initially I will change to a different progesterone pill and try that. And if that doesn't work, then I will potentially change the estrogen as well. And sometimes you have to change once, twice, sometimes longer. If they're bleeding, continue bleeding after the first few months, I'll either change to a different progesterone pill, or if they're on a low dose estrogen, increase the estrogen dose. If their periods are still heavy, then I'd change to continuous, taking the pill continuously. And I see a lot of adolescents, and the biggest problem is convincing their mothers that this blood is not accumulating. So that is the biggest hurdle to actually getting them to take it continuously. If they get chloasma, facial pigmentation, they need to stop the estrogen and go on to a progesterone-only method. Yep, next one. The NuvaRing, which I have to confess I've never prescribed, but I have seen a few women who use it. It's very similar to the OCP in terms of cycle control and side effects. They leave it in for 3 weeks and take it out for a week when they have a withdrawal bleed. They've got to remember to put it in and then take it out. And they've also got to put it in. So they have to feel comfortable enough inserting that inside their vagina, which a lot of women are not. Yep, next. Long-acting methods. Depo-Provera, I also worked in New Zealand and the UK. It's used a lot more in those countries than it is over here. I don't quite know why it's not used as much here. It stops ovulation. It lasts 3 months. You get good bleeding control long-term. 50% of them will be amenorrheic after 6 months. The minuses, you need an injection every 3 months. They usually get irregular bleeding for 3 to 4 months. If they're already getting PMS type symptoms, then often they will be worse on this because, as I showed you in that initial slide of physiology, PMS symptoms are associated with the rise in progesterone. So if you're giving them the big dose of progesterone, often they will get those symptoms as well. The other problem with them is that they do accumulate. So over a period of time, you may get prolonged amenorrhea due to anovulation for 12 to 18 months afterwards. So you wouldn't put someone on it who's planning on trying to get pregnant in 12 months or so. And if they're on it long term, there is a small risk of osteopenia. So they need to have a bone scan on a reasonably regular basis if they want to stay on that. Next, please. Implanon, very similar to Depo in terms of what it does. Stops ovulation, lasts 3 years. The minus is you've got to have someone trained to insert and remove it. You get irregular bleeding for 3 to 4 months and you get PMS symptoms. Next. The Mirena and Kalina, the only difference between the, well, not the only difference, the difference between the two hormone containing ones is that the Kalina is a smaller device, has a smaller shaft, so it's theoretically easier to put in. I put a few of them in, but tend to put in Mirenas and don't have very many problems with them. So the Kalina does have a lower dose of progestin in it. So it's levonorgestrel, 52 micrograms a day for the Mirena versus 19.2 for the Kalina. It may stop ovulation, but not certainly. The endometrium becomes non-receptive for implantation. You get the cervical mucus changes so that sperm can't get through. And I've got here lasts longer, 6 years for the Mirena, 5 years for the Kalina. And just at the start, when I was talking to Martina, she told me that it's just been approved by the TGA for 8 years for contraception here in Australia, with 5 years for heavy bleeding and 5 years in the menopause. And it is very useful as an anti-estrogen in the menopause, particularly if they've got one in there, and you put them, you can just put them on estrogen and you don't need anything else. Minuses are there's small risk of infection. You need someone confident and competent to do it. So this is not something I think you do once or twice a month. I think it's something you need to be doing once or twice a week so that you feel comfortable with it. Occasionally you can't get it through the internal os, and then they either have to choose another method or have it put in under GA. They do get irregular bleeding for 3 to 4 months. Yep. The extended use, off-label use for 6 years, that used to be that, is now 8 years, and it's no longer off-label. It's been licensed for 8 years in the USA and Europe for some time. And interestingly, the release of the amount of levonorgestrel they release at 8 years is the same as the Kalina is releasing at 5 years. And if it's inserted after the age of 45, you can use for contraception till the menopause or till 55. So it can stay in up to 10 years. So that's often what happens is they, if you put the last one in at the age of 46, then I would just leave it in there until they go through the menopause, although sometimes it's hard to work out whether they have gone through the menopause or not. Yep, next. Copper IUDs. The big plus of these is no hormones. And for lots of women, particularly following the fuss there was about hormone replacement therapy, are opposed to it. Has no effect on ovulation, has an inflammatory effect on the endometrium and is partially spermicidal and lasts up to 10 years. Again, small risk of infection. You need somebody who knows what they're doing to put it in. They will have heavier and therefore more painful periods almost invariably. Yep. So which one do you choose? So as I said, I usually put in a Mirena, so that's 52 micrograms per day, compared to Microlit, which is 30 micrograms, lasts for now 8 years, doesn't stop ovulation usually. The insertion process requires a trained person. They have irregular bleeding for 3 to 4 months and a small risk of infection. Copper one lasts 10 years, no hormones, but heavier periods. So if the woman already has heavy periods, I'll push her towards having the Mirena. But ultimately it's up to the woman to choose. Next. We mentioned Depo-Provera, lasts 3 months, easily administered, initially regular bleeding, may get some fluid retention, osteopenia long-term, prolonged anovulation due to accumulation. So those are downsides. Implanon lasts 3 years, similar side effects to the Depo, but the insertion and removal is more complicated. So I will usually suggest that they start the Depo-Provera first to see what they're like on a long-term high-dose progestin, and then if they like it, then they can move on to the Implanon. Yep. So the other major reason that I mentioned at the start that we use them is for cycle control. So I'm going to now, I've got a series of cases, short cases, just to finish with. So Talia, I must say that all the patients that I'm presenting, I've actually asked them whether they're de-identified, but I've asked them whether they're comfortable to be presented. So she's one of my babies. I mean that by that I mean that I delivered her. So in December 23, I saw her for the first time. She'd had vomiting and intermittent lower abdominal pain. She'd been seen in ED at Sutherland 3 months before. She was starting to miss a lot of school because of abdominal pain. She had a menarche at 11. She had regular periods, and the pain was worse prior to and during the period. And her mother had a history of endometriosis and was worried that she had endometriosis. So because it was mostly cyclical pain and her mother was worried about the endometriosis, I started her on some Yaz. And next. So January, so 2 months later, her pain, she'd had more pain prior to her period and then had a prolonged period for 14 days, which had settled and she was not bleeding. So she was a little better and a little happier. I convinced her and her mother to skip her periods and made an appointment to see her in 6 weeks with a view to a laparoscopy and Marina if she was no better. Yep. So saw her in March. She'd skipped a period. Her pain wasn't as bad, just in general throughout the day. She was going to school. She wasn't missing out of school, but she'd noticed that her skin, she was not as good. So put her on to Yasmin, which is a higher dose. She was skipping her periods. She had some spotting when I saw her in May. Pain was improving. The skin was much better. So I've left her on the Yasmin. She's very happy on that now, and I haven't seen her since then. I can't remember when I'm following her up. Next one. Charlotte was my receptionist daughter. I didn't actually ever see her, actually. I probably shouldn't admit that. She'd been on Roaccutane for a year. She had flaking skin around her mouth, her anus, and her hands, and her acne had not really improved. She had an irregular cycle. Her periods were often heavy, and she was becoming very school avoidant because of her embarrassment over her facial acne. So I started her on Yaz mainly on Yaz because we had a whole lot of samples from the rep here in the rooms. And next. So currently she skips a period for 3 months because she finds if she goes long than that, she'll get some breakthrough bleeding. Her skin is now perfect, and whether that's due to the Yaz or just getting older or both, it's hard to know. I've talked about it with my receptionist changing it to a cheaper pill, and we remain undecided at present. Next, please. Dina, who's 32, is my daughter, my actual daughter. She started Yaz at the age of 15 because of our parental concern about some of her risky behaviors. She took it continuously and had occasional spotting on it and got very indignant when she had spotting. Next, please. Then in February of this year, she developed headaches with aura. She's a basic physician trainee who's just sat her exams and believes that she's failed. So we're all going through this rather gloomy time at the present. So started her on Slinda, which remember is the progesterone only one. She's now taking that continuously, has a bit of spotting, but otherwise had a bit of spotting to start off with, but now has good control and very happy on it. Next, please. Now, I just want to have another 3 cases, and these are women that we're mainly treating for bleeding disorders. So the first one's 42, had 2 babies, and wasn't wanting any more children. Initially saw her in April 21 with menorrhagia. She'd had an iron infusion. She had had severe endometriosis treated previously, had a pelvic ultrasound which suggested a polyp. So we booked her for a laparoscopy, hysteroscopy, polypectomy, and possibly a marina. Although quite a few of them that we book, as an aside, that we book for a marina will come for the procedure, but have talked themselves out of having the marina. So, however, it was cancelled due to COVID. And I next saw her, as you'll see, 2.5 years later. She was on Levelin, which I hadn't prescribed. She was still having heavy irregular bleeding, unusually. Tranexamic acid helped that. She had an ultrasound which showed multiple small fibroids, but none of these were intracavity. And after going through the options, we decided on an endometrial ablation. Next slide, please. And next. So she had an ablation in January, and you'll see on the left, this is what a normal hysteroscopy looks like. The sort of slightly orangey pink normal endometrium. And on the right side, this is what it looks like, a wasteland after she's had an ablation. But the device hadn't burnt some on the left-hand side, or the right looking at it now. So we ablated some more on that side, and you can see there's actually a small submucosal fibroid which came into view with doing that. So removed that as well. Next, please. And by chance, she came up 3 weeks ago from Tasmania. It's just over 4 months from the surgery. She was still on Levelin because the ablation is not a sterilization, although it is partial, makes them much less likely to fall pregnant. She'd had no bleeding for 2 months. She then had a recent period which has been very light, and she was very happy with it. And my only suggestions whether she took the Levelin continuously rather than cyclically, and then probably stop at 50. You need to stop at around that time to as long as they have no risk factors, to see whether they are actually menopausal, because they have a completely artificial cycle, pardon me, and as long as you keep them on the Levelin, they are going to go on having periods. Next, please. Another lady, 3 babies, came with menorrhagia. I'd seen her before in 2016 for a last postnatal visit. Then I saw her in January. She'd been on Zoli, prescribed by someone else, and had headaches for 2 days prior to the period, which had been made worse by the Zoli. She wanted a sterilization. We'd booked it for February, and it didn't happen. Next. So then I saw her this year, as she'd been flooding for the last month. Her cycle had become very irregular, between 22 and 66 days, but she had noticed that she had mid-cycle pain at times, had an ultrasound which showed a polyp. So I started her on some norethisterone to stop her bleeding, and booked her for a hysteroscopy and polypectomy. And again, despite my best efforts, she didn't want to have a marina. Next. And this is what we found on hysteroscopy. There was no polyp to see, and find that in about 10% of these that you don't see any polyp at all. At the top of it, you'll see those are bubbles because you put fluid inside, and the brown spots you can see at the back are just hemosiderin from having the heavy bleeding that she had, and the histology showed secretory endometrium. Next, please. So I prescribed Slinda continuously for her because she needs menstrual control. She didn't want a marina or other long-acting method. She had headaches on the combined pill, and I wanted to stop ovulation as she had this mid-cycle pain. Next, please. So when I saw her at 7 weeks, she'd had some spotting. She had no period. She had a migraine mid-cycle. I'm not sure how she knew it was mid-cycle, but given that she hadn't had a period, but she thought that this might have been because she'd spent the day out in the sun. So she was very happy on that, and I haven't seen her since. Next. So this last one was a bit of a journey. So she'd had 3 babies before. The last one was September 2019. She's on the low dose of thyroxine. In December 2019, I inserted a copper device because she said she wouldn't remember pills and didn't want to have hormones under any circumstances. Next, please. Then saw her 2 months later. She'd had, after putting it in, 2 periods, both very heavy, and we decided that we'd wait for 2 periods, and if it was still heavy, change it to a Mirena. Next. Then didn't see her again for over 2 years. She had some pain on intercourse on the right side. She had a smelly yellow discharge. I put her on some vaginal clindamycin and organised a pelvic ultrasound. Next. On ultrasound, the IUD was sitting in the cervix. Her discharge had improved after the clindamycin, but had returned. So I removed the IUD, and when I was doing it, her cervix was very tender on manipulation. So it was clear that she had a cervical infection, although she hadn't complained about this particularly. I started her on some Augmentin, gave her some azithromycin, and started her on Yasmin. Her swabs were negative for chlamydia and gonorrhea. Yep. And then saw her 19 months later. She'd had a spontaneous miscarriage and a curette for retained products in November of last year. So my putting her on Yasmin, she hadn't liked that at all and had stopped taking it, and she had got pregnant, surprisingly. And so we then planned to put a Mirena in. Next, please. So I saw her on the 12th of April. She had a bit of a discharge. It wasn't that excessive. I inserted a Mirena. Next. A week later by phone, she said she had a smelly yellow-green discharge. I gave her some Augmentin. Next. And then 5 weeks later, I phoned by phone. She had no discharge. It was feeling a bit crampy, and she'd been bleeding heavily with clots. And next, I don't know what's happened since then. So that is what, 5 or 6 weeks now. So whether she's better or she's fed up with me and gone to see someone else, I don't know. Question is whether you put in a Mirena with a possible pelvic infection. She had an IUD in successfully before, so she certainly didn't have any symptoms at the current time, so I wasn't too concerned. Next, please. So to conclude, there really is no right choice. You need to be clear about your treatment goals and what the woman wants. There are multiple oral contraceptive options, and you need to get used to a few, and you will often need to tweak them. I tend to push the long-acting methods, but I see a lot of women who've finished their families and have small children, so I think these are very good options for them. There are very good reviews on methods and choice in the health pathways. And next slide, please. And as you can see there, the clinical pathways, a lot about contraception, emergency contraception that I haven't talked about. So I think, Martina, can I hand over to you to just talk a bit about the pathways?
Yeah, sure. Thanks, Greg. So as you can see, we've got quite a lot of health pathways on contraceptions, and they're kept up to date with our subject matter experts being people from family planning. So they're really helpful to refer to if you are wanting to reinforce what you've learned today from Greg. Just to point out also that we have in draft prescribing MS step, and the only thing that's up here is just getting the details right for use of MS2 step in an early miscarriage and getting anti-D information that's agreed upon, because there's a little bit controversial amongst the people that are giving us advice, but to be available sometime in next month as well. So hopefully you find them helpful. Greg, I've got a few questions for you, and I've also got one for Noreen. So I might ask Noreen's one first, if that's all right.
Sure.
Noreen, you mentioned having a morphology scan at 18 to 20 weeks to assess as part of the assessment for risk of premature rupture of membranes. And the question is, does the routine morphology scan measure the cervical length, or do we need to request it?
Sorry.
Noreen
Yes.
hasn't.
I'm here. Hi, can you hear me?
Great.
Yeah.
Yes, we can.
So yes, you'd be better off to write it on the request cervical length, and we can do a transabdominal or transvaginal length. So if it's transabdominal, it's 25 millimeters. If it's transvaginal, it's 35 millimeters. Would be the shorter than that. So yeah, so all scans now tend to have that cervical length noted.
We just need to take notice of it. Thanks very much, Noreen.
My pleasure.
Greg, the first question for you is, which are the less androgenic contraceptive pills?
All the newer ones, basically. And so that's why I use Marvelon. If price is an issue, Marvelon in trials with Diane was equally good at treating acne. So I will use Marvelon because it's cheaper, and yeah, and it's just a newer pill, and you tend to have fewer side effects, other side effects from Marvelon compared to putting them on Diane and those older ones as well.
Thanks very much. I just noticed Bertha's just posted in the chat the link to the updated Marina engine with the TGA that says that 8 years for anyone who wants to check the source themselves rather than believing me.
It's enough for me, Martina. I believe you.
Thanks, Greg. There's a question. Could you please comment on the different types of copper IUD and when one would be used over the other, apart from duration of treatment?
I don't think there's a lot of difference between them. I've put both of them in. I tend to use the copper load 375 because it's like the multi-load. It's just so I'm used to using it. The copper T is the mechanism for putting it in is slightly different. So I have to sit there and because I do a clinic once a month at the public, and that's when I put most of them in. I have to sit there with the instructions each time I do it to read the instructions, which is probably not as cool in terms of looking slick, but yeah, I mean, it's not difficult to use. So I tend to use whatever the woman's brought in. So I don't see a lot of difference between them.
Thank you. There's another question. How long can people skip their periods safely if they're using the continuous combined pill?
Forever.
That's what I was hoping you'd say.
And so and there's this kind of myth out there that prolonged use of the pill is somehow will impair fertility. But in fact, there is now good evidence that it is the reverse, and that you get less, because the woman's not ovulating on a regular basis, you actually get less scarring inside the ovary itself. And it actually, so it will protect her fertility. And if you actually look at the fertility rate as soon as they come off the pill, it's slightly better than what it was before they actually even started the pill. So, I mean, as I said, it is a real issue actually convincing their mothers. And what you have to say is that I then go through that little story about what happens in a normal menstrual cycle. And the reason that you have a period is because you're taking away the progesterone. And when they invented the pill, they put in these pill-free days so that women could feel more normal. But there's no medical reason that you need to have a period. And so, as I said, with my daughter, she was on it for 19 years continuously. Mind you, she hasn't had babies yet, so that's probably a good thing. So anyway, so I mean, there's no medical reason for thinking that you should stop it. As I said, gave the example of my receptionist daughter Charlotte. Sometimes some women find that they will have a period and have it every 2 or 3 months, because otherwise they get breakthrough bleeding in between times. But that's what I mean about these things. You need to be very individual in terms of how you deal with them, I think.
Yeah, I often tell them if they've had 21 continuous pills or at least, then if to get breakthrough bleeding that's troublesome, give themselves a break so they can have a withdrawal bleed and then get started again.
Yeah, I agree with that, Martina. So I will often tell them that too. If they actually start bleeding, they ring you up. I'll say, yeah, just take 7 days off and then get back on it again as well.
Again.
Yeah, I find that.
There's some interest in Talia. The question is, why was increasing the estrogen dose chosen over changing progesterone for acne management? You had her on Yaz, you put her on Yasmin, and said if Yaz was not tolerated for dysphoria, but acne was an ongoing issue. Sorry, so there's 2 parts of the question. The first is, why did you choose to increase the estrogen dose? Because I'll ask you the second part after.
Yeah, so the estrogen is what really makes the difference with acne. So if you're wanting to treat the acne, you need estrogen. And with her, the big problem was that it actually made her skin worse. So that's why I increased the estrogen with her.
And then the other question was, if Yaz was not tolerated because of dysphoria, but acne was an ongoing issue, what pill would you have suggested?
That's a very good question. So
maybe aspirin one? Oh no, that is Yaz, isn't it? Yeah.
Yeah. So I mean, she needs estrogen. So I mean, I would have probably put her on one of the newer estradiol pills, the one that got estradiol in it, and so change the estrogen that you're using. It's more expensive, but I mean, I think in those situations you've got to. It's really just trial and error. But I would put her on a different estrogen.
Next question. Please comment on breast cancer risks in oral contraceptive pill and your LARCs.
Yeah. LARCs, the progesterone only ones, the risk is incredibly low. So it's negligible. The breast cancer thing there's an incredibly small increase in risk. So I can't remember off the top of my head the exact figure, although I have read it recently. But it's incredibly small. So and as I said, the really interesting factor is that women on the pill actually have a lower death rate overall than women who are not on the pill. So, there might be a tiny increase in the risk of breast cancer, but overall, their health is going to be better.
Another question is, which pills would be better for prevention of breakthrough bleeding when you're trying to skip periods?
Look, I think, I mean, I think that's why I tend to use the newer ones, because I feel that you get less breakthrough bleeding with that. The companies have produced these pills because they are theoretically better, and I think that's probably true. So I tend to use the newer ones, but then I think you just have to, as I said, change the progesterone, or potentially increase the estrogen if they're on a low estrogen pill. Because as I said, the estrogen is the main reason. You have the estrogen in there to actually control the bleeding. That's the main reason for it being there.
There was maybe a little bit of confusion because you had a few cases where you planned to do curette and then insert an IUD, and it may have led to a misapprehension that people need to have a curette before they have IUDs inserted.
Not at all.
But yeah.
So the reason I was doing that was that, I mean, in both cases, I was, if there's a polyp present on ultrasound, you need to do the hysteroscopy and remove the polyp. And I was also putting a marina in, not for that reason, but to treat the bleeding. So it was just, a rather than seeing you're going to be there, you might as well do the job and put the marina in. Because if I am ending up doing a hysteroscopy on someone, I'll be quite persuasive for them to try a marina, because you are going to be there, and I will say to them, if you don't like it, it takes 30 seconds to take it out, and it's very simple to remove. So it just seems efficient to me.
I agree. But I think it's safe to say that the majority of marinas are actually inserted in doctor's office without a curette beforehand.
Absolutely. So I think, if you're doing it for contraception and they have normal cycle and things like that, you would just put it in. If you're doing it because they've got heavy periods, menorrhagia, or some sort of irregular bleeding, they need to have a pelvic ultrasound before you put it in. So I do a pelvic ultrasound first, and then obviously if there's any intrauterine pathology, they need to have a hysteroscopy and lobectomy or curette, and put in the marina at the same time.
We've come to the end of our time. There's one last question. Comment on using the morning after pill often. Define often. But do you have any concerns?
Well, I mean, no, not at all. I mean, it's basically like taking the progesterone only pill. So it's just, I mean, it just is a worrying form of behavior if you're continuing to have unprotected intercourse, and just using that as your means of contraception. And if a woman chooses to do that, that's her right. But I think you need to explain to her that is probably not the wisest course in terms of contraception. But at the end of the day, it's her choice.
Yeah, or her circumstances. Yeah. Okay. Thank you very much, Greg. That's all of the questions, and thanks for so many questions. It's because it's always nice to have the opportunity to have a bit of backwards and forths. Bertha, I'll hand it to close.
Okay.
Thanks, Martina. I would like to thank Associate Professor Davis for his presentation tonight. Thank you, Noreen and Martina, for facilitating tonight's session. Big thank you to everybody for attending as well tonight and participating with the discussion. We will now end the session, and the evaluation survey will pop up on your screens. Please visit our website to see other upcoming events, and enjoy the rest of your night. Thank you.
Bye.
Thanks very much. Bye-bye.